case study. So we have a patient with a fracture of the dorsal fragment. What I did, I pass a wire extra-articular into the middle phalanx. So this wire is immobilizing this, and that another wire is pushing the distal phalanx dorsally. So you have a good alignment by Ishiguro technique. On the patient, fracture dislocation, I did open reduction. This was 2006, long time back. I did things before I learned Ishiguro technique, and opened it, and again you put this fragment back into alignment. Now this as again the Ishiguro, this wire is going through the fracture site to the fragment. Once this is brought into alignment, another wire to neutralize it, and this also gives a good result. But important thing is splinting to mobilize. If you don't have a splinting, you will have only a splint with you'll have a finger which is stiff. The mechanism of injury of fracture dislocation and mallet is same, the ball hitting the tip, and you can have both the injuries, and they will require management of both PIP joint and this also. So here, because there is no dorsal V, I decided to fix this with a bony fixation with K wires and had a good range of motion. But important thing, the amount of flexion you get with a normal and amount of flexion you get as affected may be slightly less unless you continue with the sprinting for a very long time, which may be 6 months to a year. Often the patient get bored and they abandon treatment after getting some range of motion. But this has to be discussed with the patient. Another method that I've immobilized is, once I removed, now often suturing of the tendon has been described over the button. But I feel if you repair a tendon over a button, if the hold is tight enough, there will be pressure necrosis under a button. And therefore for me the button is an eyewash, it doesn't work. And therefore to offset that, what I did, I had a pull out suture, put a wire into the bone, and on top of the wire, on the bent wire, I pulled the tendon and repaired it, so that there is no pressure sore on this thing. And that can be a technique you can utilize if there is a non-bony avulsion of the extensor tendon. Now close pinning is not a blind technique. You decide to put wires wherever and still have a drooping, the patient will be unhappy. And therefore you have to do a perfect reduction, maintain DIP and extension, otherwise this will fall apart, and therefore absolutely no. Whether you treat it surgically or non-surgically, being an intra-articular injury, cartilage damage is likely and degenerative changes can occur in majority of them. Now degenerative doesn't mean it is painful. You may see some changes on the X-ray which may in some patient become painful. But again, the point is discuss with the patient. Whatever you do, some degenerative changes are likely to occur, and therefore you should be aware of this. Again, very important thing, whether you treat it conservatively or not, patient has to be a part of the decision making. If you're treating conservatively, they should be aware you have to wear the splint continuously. He is not happy with the splint, he is thinking, take out the splint, but maintain it in extension till you wipe it, wash it and reapply it. If you take it out, you have to start counting 6 to 8 weeks from that time again. Now this was a gentleman who came because this deformity is not acceptable and because he has been rejected by defense services. So what I did, I removed a part of this bone from here, because I said in the first slide, even 1 millimeter of lengthening can give 25 degree of drooping. And therefore just remove 2 millimeter of this bone, get that into extension, refix it like a fresh fracture, and you will be fine. Patient can present late, like this patient, a swan neck deformity, an elderly lady, but she said, no, I don't like this swan neck deformity, do whatever to correct this, and she came in for this surgery. So if the joints are flexible, this is some of the sprints that we utilize. 3-point fixation device to mobilize the joint is stiff. The joint is mobilized with the device, and now there are options which are available. So what I did, I reconstructed the tendon. So for this mallet, a palmaris longus tendon was harvested, and this tendon was weaved into the distal remnant and was passed dorsal to the DIP joint, brought to the middle phalanx volar aspect. And once this was brought dorsally, you see this is able to correct the DIP joint flexion and get the extension. And now this palmaris longus is brought here, and now it will be passed to the other side. So it is passed from the dorsum to the volar and weaved to the other side. So this is called a spiral oblique retinaculum ligament SORL reconstruction, and sure enough you could correct this drooping, and this patient temporarily put a K wire so that this is correct. Slightly make it over tight so that this is tight, but because over a period of time this will get stretched. So this is for chronic mallet deformities. So in summary, they are not to be ignored, they have to be treated. Conservatively, non-bony will require prolonged immobilization uninterrupted of 6 to 8 weeks. Surgery, many options are available. Ishiguro technique, if you have learned here, is a reasonable option. But whatever you choose, patient has to be a part of the decision making. If chronic, long-standing, patient wants a correction, ligament weaving with a palmaris longus is the good option.